CTO pathology, and the speaker is Dr. Priyen Kantilall Shah.
Good afternoon, Lucknow. Good afternoon, respected chairpersons and the august gathering. My sincere thanks to Professor Goel for invite. And my lecture is pertaining to the womb of CTO. Yeah, why pathology? All CTO lesions are not the same, and it's important to understand the CTO lesion. Understanding the CTO pathology helps the operator for stratifying the PCI and helps the hardware industry to develop equipment in collaboration with the physician. Per se, we all know CTOs are defined as 100% occlusion in the coronary with TIMI zero flow of at least 3 months duration. However, angiographically, total occlusion does not correspond to the histologically total occlusion. The histological definition of CTO states the lumen area to be occupied by proteoglycan and or collagen with or without neovascularization and chronic inflammation from the resolved thrombus and in some progression of the atheroma. The morphologic characteristics of CTO, as we see in acute CTO, the lumen is closed with the thrombus. In early CTO, the proteoglycan and the matrix is seen, and in late CTO with negative remodeling, there is collagen and increased calcium, and still late CTO with physiological recanalization, that is the vessels have grown in. Pathologically, CTOs are classified into long duration and short duration. Long duration CTOs consist predominantly of type 1 collagen in the absence of fibrin in all sections of CTO with negative remodeling. But in short duration, it is composed proteoglycan with or without recanalization and inflammation, but fibrin had to be identified in at least one of the sections. The slides, it shows the long duration CTO in high power images, the collagen type 1, and in high power for the short duration showing the proteoglycan and the fibrin. 18-month CTO shows organized thrombus with microchannel, and 5-year-old showing fibrous tissue and calcium without any microchannels. So understanding the pathology of CTO is a fusion from the history to today's equipped cath lab. The postmortem studies, coronary angiography, MSCT, intravascular ultrasound, OCT, angioscopy, and learn from the experts and self-experience. So the components of CTO, basically for pathology, it's the plaque morphology, proximal cap, the body of the CTO, distal cap, remodeling, and extraluminal pathology. One of the largest human autopsy study done by Sakakura and his colleagues had compared the plaque component showing necrotic area highest in the short duration CTO and calcified area was highest in the CTO plus CABG. Negative remodeling was least in the short duration CTO. 50% were of proximal lumen abrupt closures, and 79% distal lumen were tapered, a very important thing. So proximal caps are of two types, tapered and blunt. The proximal cap is usually a rich fibrous tissue laced with calcium with recanalized channels of 200 millimicrons or less in diameters. The tapered proximal cap, the microchannels are surrounded by loose fibrous tissue and they are of short occlusion length. The polymer jacketed wires with tapered tip, low tip load like Filter XT, XTR and XTR quite helpful to penetrate the cap. Whereas a blunt proximal cap, it's more of calcium, no stump, microchannels are rare, The lumen extends to the side branch. The guide wire gets deflected to the side branch. As we know, dimples are very, very lucky on the face. So also a dimple in the stump occlusion can be also lucky for us to penetrate. So stiffer wires like Gaia series will be helpful. Parallel wire and IVUS in the side branch can help to puncture. Look out also for an eccentric orient stump, which will be of high probability for the subintimal navigation. The proximal cap studies done histologically by Katsurgawa had shown the tapering type or with a short occluded segment or both is possibly favorable for angioplasty. The body of the CTO, as we know, the length, it will be with loose and fibrous calcium and microchannels. Kumamoto and Srivastava has done extensive study on it and had shown intimal neovascularization largely originates from the adventitia, and the intimal plaque with neovascular channel growth derived from the adventitia increases with age and is strongly associated with intimal plaque cellular inflammation. By Sakakura, it's a slide showing how the microchannels are seen. They are of usually from 40 millimicrons and they can extend up to 800 millimicrons. So microchannels no doubt increases the success with hydrophilic wires and low profile tips facilitate the crossing. But a calcified plaque is of concern with lower success. The distal cap, which is fibrous and calcium, and it is less resistant and has given the genesis for the retrograde approach and was seen by Sarmli and Osawa studies. The results suggest that retrograde approach may be an effective by understanding the distal cap well. The extraluminal pathology basically of loose tissue tracking, intentional intimal plaque tracking, and subintimal tracking. The loose tissue tracking is through the microchannels, which was observed in adventitia of young CTOs, and the continuity of these channels was observed in 85% of the total CTO length. In case we are failure to the loose tissue tracking, it requires intermediate or stiff wire, which was well achieved by the Pikachu trial, a worldwide trial for which wire to start. And this particular had shown we should be able to control the wire tip and intimal plaque resistance surrounding the wire tip relatively high but homogeneous. And the wire tends towards the tip tends towards the true lumen. The antegrade subintimal tracking, the enlargement of the space leading to true lumen collapse, re-entry from subintima to intima is very difficult, but expert hands can do it, and various techniques have been described like star, mini-star, contrast, last, crossboss, and stingray. In retrograde subintimal tracking, the tracking is considered to be a factor of success rather than failure, as distal cap is less rigid than proximal. As described by Strauss, the microvessel formation within the arterial CTO is a complex process, and the presence of particular extracellular matrix environment in the adjacent perivascular tissue that is surrounding the microvessels can facilitate the guide wire and for a successful PCI. Remodeling, the acute thrombi from the plaque rupture are associated with positive vascular remodeling based on the animal studies. However, organization of an acute occlusive thrombus consisting of inflammation, angiogenesis, smooth muscle cells, laydown of proteoglycan matrix, and collagen type 3 and type 1, which cross links with the resulting shrinkage of the vessel, that is called the negative remodeling, and it is seen in the long duration CTOs. There is an index, and it shows that the severe negative remodeling was defined as the remodeling index less than 0.50, which is seen in the long duration. And this is a comparison of the negative remodeling between the 4 types of CTO sections that organizing thrombus, and as time passes, it goes on to the calcified CTO, and the shrinkage takes place with type 1 collagen, which is rich CTO, and that is how the development of the negative remodeling within the vessel is seen. IVUS, which is nowadays routinely used in the lab, that is the virtual histology intravascular ultrasound. Guo Mintz and his colleagues have shown histologically intravascular ultrasound, that is VH, virtual histology, to investigate the plaque composition, and 2 patterns were seen with and without fibroatheroma of the virtual histology. Other publications and studies have shown the morphological characteristics and duration of the occlusion by Suzuki and Nishida. And as the time progresses, the plaque composition becomes more larger of calcific burden, and it is more growth of calcium is seen in long standing. OCT, it was to evaluate the plaque characteristic of a CTO lesion, and it was seen that lipid plaque and thrombus are significantly observed in patients with blunt type. Hence, we can stratify the procedure. MSCT, just now Dr. Rajesh and even Dr. Suryaprakash Rao has just talked. So I'll just put over, tell one line. It helps in plaque characterization, the length, course. Retrospective analysis have been done, which shows significantly higher success rates if we do a pre-procedural MSCT. Angioscopy, which is a direct visualization, and very few reports have been there, and it was done by Takayoshi Adachi at Japan, and what we are able to see in this picture is the white one is the thrombus and the yellow is the plaque, and that is with the direct visualization. But here only the proximal cap can be visualized, not the distal cap. But in peripheral vessel disease, they have tried to see the distal cap also for a retrograde approach. Very limited reports are there. Then we have got high resolution angioscopy with scanning fiber endoscope, which shown the proximal cap, and
Shah,
yeah,
please.
yeah, another 1 minute. Yeah, and it shown that microchannels can be seen, and we can go through it. Micro CT axial slices, it's only an animal study. In summary, pathology understanding is a way to successful PCI. Success is an alliance between patient, physician, equipment, and the industry. It consists of various degrees of fibroatheromatous plaque and thrombus depending on the mechanism of occlusion and its duration. A tough fibrous cap is often present at the proximal and distal margins of the CTO, with in between softer material. Majority of the endothelialized microchannels are less than 40 millimicrons. Long duration CTO without CABG demonstrated severe negative remodeling, and severe calcification observed in CTO with CABG, hence success rate is a concern. Tapering lumen in the distal lumen is an advantage for the retrograde approach. Understanding the pathology is the key to the successful CTO PCI. Thank you.
Thank you very much. So probably due to the time constraint, we go on to the next session if there is any question or the comment.
Thank you very much, chairpersons. We'd like to thank all the chairpersons of this opening session, and we move on to the next